Everyone, welcome to another session. I've got Moira with me. I've got Dr. Raji. Myself, I'm Dr. Sunita Daniel. If probably you must be familiar with me if you've watched the webinar on today's topic. I'm a palliative physician working in Kochi, and I've got my co-host and co-facilitator, Dr. Raji, who's also a palliative care physician working in, who's got years of experience, and she's working in Calicut and Kochi. And I've got Moira with me. Moira, would you like to update on what happened yesterday? Because I was unable to join, and then we can take it from there. Over to you, Moira.
Thank you, Sunita. And I just want to welcome everyone. I see familiar faces from yesterday. I also want to welcome some new faculty who are going to be particularly teaching from Nepal today. Thank you for joining us. We had a good session yesterday. People interacted really well, and you brought up a lot of issues for us to explore this week. And you particularly focused on the communication aspects. But I know you're going to enjoy today with two excellent faculty. Please do continue that interaction style so that we are sharing and learning from one another, as well as being facilitated by our two excellent faculty who are part of the founding team that developed this program. So I think with those introductions, I'll hand back to Sunita and Raji, and they can introduce themselves in more detail. Thank you.
Thanks, Moira. So we're hoping to make this session as interactive as possible, just like yesterday. And I'm sure you must all be familiar with the chat functions. So I'll start with sharing the screen. Are the slides visible now?
Yes, ma'am.
Okay. So this is a part of the entire resource toolkit, and I'm hoping that you must have had a chance to go through the resource toolkit, which was shared to you when you registered for the course. And I'm just doing one of the sessions, and as we mentioned earlier, hoping to make this as interactive as possible. And this one single echo session, what we're hoping to cover is to make you familiarized with the symptoms of COVID-19, as well as the algorithms, so various algorithms that is mentioned in the ebook. So we just want to make sure you understand those algorithms, and I just to share with you all how we came about doing that. And also there's a list of essential medications which has been uploaded in the ebook, and again to make you familiarized with that. That's what we hope to achieve with this session. So coming to our patient, Ramesh, whom I'm sure you've been introduced yesterday. So we'll start with the discussion about Ramesh's condition. So what's happened now is Suresh, Ramesh's son, he calls the COVID-19 helpline, and he says his father has symptoms of sore throat and dry cough. So basically when they heard that, the medical officer advised them to move Ramesh to a nearest COVID treatment center. They immediately tested him and found that the result is positive for COVID-19, unfortunately. So as we all know, Ramesh was initially also very anxious because his son had come back from Middle East. So now he's clearly anxious, now he's unsettled. And he keeps on asking his family, will I ever see them again? So I would like to pause here now, and I would like you all to tell me, what do you think is happening in Ramesh's and Suresh's mind? What are they thinking about? And what are the specific issues? And if you as a medical officer, if Ramesh is asking you this question, how will you respond to them? So please feel free to type in the chat boxes, and myself and Dr. Raji will be keeping an eye on that, and we can make it, so I'll give you some time to think about this. Over to you, Raji, ma'am. I'm trying to find my chat box. So what do you think is happening? If Ramesh asks you that question, will I ever see them again? How will you actually respond to that? Why do you think Ramesh is asking that question? What's in his mind?
Sunita, the responses are coming one by one. Anxiety due to uncertainty because he doesn't know what is going to happen. Yes, of course, another response that he is anxious. Yes, fear of death, of course. And I mean, because every day we are getting a lot of information like, depicting the mortality rate, and also Ramesh is really scared of death and he's worried about that. Okay, come on, please keep posting.
So how are you going to respond to that? It's interesting to know that even though we know that mortality rate as such is not that high for COVID, immediately there's a lot of stigma associated with the disease.
Exactly.
So we do think of death. Yeah.
Yes, uncertain what will happen. I think telling him truth.
Mm-hmm.
No, like suppose if you are going to reveal the information. It's not only about the information. Probably about the treatment and the isolation. He's worried about the prognosis. And of course, one comment is there from Rodora. We will do our best so that you may see them, and we will make a way.
Yeah.
Okay, and Lord Source, sorry if I have pronounced it wrongly, no complete knowledge about the health condition and prognosis. Yes, we are still learning a lot about COVID. So none of us are so sure about the information, we are not sure whether we will be able to provide the appropriate or accurate answer for the questions they raise. Yes, it's very true. That escalates anxiety. Then correct the misperception that Ramesh might be having against COVID-19. Okay. Whatever misperception Ramesh is having, that should be corrected and spread to the family. Yes. He has been living with his family, so there could be fear of contagion. We can first apprise about the current status and level of understanding regarding the illness. Yes, very good, Rashia. Like. We can ask him like what does he know about his current status and level of understanding about COVID-19. So in that way, probably we will be able to alleviate some kind of misperception or anxiety which he is having, and listen to Suresh and everything he has to say patiently. Yes, of course, listening is a key in the healthcare practice, particularly in palliative care. So listening to Suresh. Okay, is it to Suresh? Suresh, of course, to be listened, but is it Suresh or Ramesh?
Suresh's son, I think.
Yeah,
that's
Suresh.
what they meant.
Okay. Yeah. Anyway, we have to listen to the patient as well as the family member as well. Okay. Good responses. Keep posted.
Yeah. So thank you very much. I think as a team, we have covered most of the points. So the finances we mentioned, about the anxiety about dying, the communication issues, include the family. So as a team, we should make it as a step to, as a plan to, manage Ramesh well. So moving on, things have changed again. After admission on day 2, Ramesh unfortunately deteriorates. His condition worsens. He's got high fever now. He's got a dry cough. He's got difficulty breathing, and he's feeling very tired and he's unwell. When you examine him, he's tachycardic. His pyrexia, its SATs is 88%. His BP is stable. So the clinical team, after having a discussion and using all the algorithms and guidelines that we discussed yesterday, decided that probably it's not in the best interest to transfer Ramesh to a critical care facility. It's not recommended, and they want to focus on excellent symptom control. Now, the medical officer is worried how they're going to inform him and the family. So that it's a team decision, but the medical officer who's in the front line feels worried about how to speak to the family about this. And the son has been calling. The son obviously can't see Ramesh, but he's been calling and telling, please do everything for my family. So how will you handle this situation? And if you can actually just remind me about what are the comorbidities that Ramesh had from yesterday, because I was not there for yesterday's session. So if you could probably put in the chat box about comorbidities Ramesh shared, and how did the clinical team actually make this decision about Ramesh? If you can help me with that, and then we can take on with this question about how are we going to address the son's situation, son's question.
Suresh Ramesh's son, probably who has not understood the scenario well, and because of his compassion and love to his father, so he is just pleading to the professionals that please do everything the best possible to my father. And I'm not worried about the cost and other aspects of the treatment. You do the best possible. So what are the issues which we need to consider? Please be waiting for your comments in the chat box, please.
As a clinical doctor, as a clinical team, what do you think is the best course of action, based on what you learned from yesterday? Put forward your comments. Do you agree with the clinical team that probably it's not the best interest of Ramesh to transfer him to critical care facility? If not, you can put your chat, and if you agree also, please put in why.
It's coming. Communication with the family is very important, and decision making is critical here. Okay, call for family conference to explain. Virtual family meeting with palliative care. Yeah, that's very true. We need to consult, we need to interact with the family members regarding the decision making. But what will be the decision making based on yesterday's session? So how important is critical care or aggressive management for Ramesh with respect to his comorbid status and COVID status? How useful it will be to him? The sessions are run in serial manner, so we have to think of what we had learned on the previous day. Yesterday, the most of the group agreed that
Okay, they would want escalate treatment.
want escalate treatment, but also share this conversation with family are very difficult. It's absolutely right.
Mm-hmm.
Looking at the advanced care directives that are in place for Ramesh. Okay. Probably if he has not made anything. Patient-centered family, inclusive decision making, absolutely right. Yes. So you have agreed against, all of us have agreed against aggressive or invasive ventilation or other modes of treatment for Ramesh. So now the problem is to invite a family meeting and inform family regarding the decision, and it should be a shared decision making. Okay.
Okay. So as Moira mentioned, I think most of it agree with the fact that we are not going to transfer Ramesh to critical care. So the important thing is how do you communicate that, and this will be hopefully be covered in tomorrow's session. We have detailed session communication skills tomorrow that will give you some tips and help you with the communication issues. So moving on. What is different? Why is palliative care? Why are we having a specific course? Just for PalliCovid or for the COVID situation, and what we find from palliative care physicians themselves who has looked after COVID patients is that it's a very difficult situation. It's a completely different scenario to the normal palliative care situation. It's what we call as an ultra emergency situation, where we have to have a new definition for the role of palliative care, where there is, the conventional way when we deal with the patients and family, that relationship is unfortunately lost in this stage. And the main thing is because things are deteriorating pretty quickly, that we don't have the typical timing, the palliation timing for sharing and planning. And things change so much, so quickly that it's traumatic for both the family and the members of treating team. So that is why, this is like an ultra emergent situation, and it's different from the other scenario or other cases that we normally see as palliative care physicians. I won't go into details about what the symptoms we see, but just to list the common symptoms, we all know fever, cough, dyspnea, still tops the list. Even though about altered taste and smell, we need to worry about that also, and patients have presented with that. I just want to mention about, there were some questions about long COVID, which I'll briefly mention. So there has been reports of long COVID, which is basically persistence of COVID symptoms, even after when they become well after that. So what we've seen is that most patients usually recover within 2 weeks, but 10% of patients still have symptoms after 3 weeks. And some actually can have symptoms for months. And the commonly reported symptoms are, cough, low-grade fever, fatigue, dyspnea, chest pain, myalgia, headaches, and some reports actually neurocognitive and mental health problems. When I conclude the session, I'll give you a link for the up-to-date, resources about long COVID, the latest evidence. I can give you a link for that towards the end of this session. So I just wanted to mention a long COVID because that was not covered in the webinar. Again, I won't go into details in this slide. This is given in the, it's in the webinar, which again, it tells about the pathophysiology and staging at different stages and how COVID develops and what can be tried at different stage. The only two things that I wanted to mention in this is since the webinar was recorded, we've had some evidence with remdesivir, which has been shown to cut the recovery times, but there is no evidence in survival. And obviously, you must have all heard of dexamethasone. So dexamethasone, 6 milligram, reduced the deaths by 1/3 in ventilated patients and 1/5 in other patients receiving oxygen only. So this has happened since the webinar was recorded, and that's why I thought I'll mention that. All the others, this is a very busy slide, but it's been covered in the webinar. So coming back to Ramesh, so everyone is in agreement that Ramesh should have a conservative treatment based on his comorbidities and previous performance status and the present deterioration. And we know that the son has told us, please make sure he does not suffer. So you want to make sure that Ramesh gets the best symptom control and support and have started him on high flow oxygen. Chest X-ray shows bilateral lung infiltrates, and he has got D-dimer, so further investigate raised D-dimer, leukopenia, and raised transaminases. I'm really sorry, my kids are actually chatting in the background. I'll just make them quiet. Hold on a sec. Neka. Okay. Right, so sorry about that. So chest X-ray shows bilateral lung infiltrates. He has raised D-dimer, leukopenia, and raised transaminases. So you as a medical officer, you're discussing with senior colleagues, what questions do you want to ask about Ramesh's condition, about his symptom management, and what are the key issues in the control of symptom of breathlessness? Please put in the chat box. What do you think? What are the key issues in control of symptom of breathlessness? How are you going to proceed with that?
Ramesh's son Suresh is waiting. So
what do you think? So what are the vitals? So Ramesh is breathless. So what will you give him first? How do you make him comfortable? A breathless patient, he's hypoxic. So what all can you do now to make Ramesh comfortable? Yeah. So how will you? Pallavi has mentioned his symptoms can be elevated. So how can we do that?
Proper positioning and oxygen. Okay. Pain control. Very good. Okay. Empathy. Alleviating anxiety secretions. So we have so far positioning Ramesh so that his ventilation will be maintained reasonably well, and if appropriate toxin therapy can be given, and then anxiety should definitely be alleviated and secretion should be reduced so that he can breathe easily. So do we give antibiotics? That's a question by Rodoro. Plan for the best supportive care symptom management. Are they still considering antivirals? How available is NIHFM? Sorry, I'm not sure about that. What is that?
Is it
Non-invasive high flow oxygen
non-invasive
profile.
high flow? Yeah, yeah.
Okay. And for the query whether we have to start antibiotics, there is another response. If the culture doesn't show anything, pumping in antibiotics will be futile because it's an acute viral illness. So antibiotics, unless indicated, will not be given. Okay, good. So, I mean, we are glad that you are advocating against polypharmacy in a patient who is the path of deterioration. That is well appreciated. Do we start antivirals? Definitely, that would have been done by the treating primary care team. Our role as a palliative care physician. Use of steroids in a diabetic. I mean, like it's mentioned by Sunita, I think already. I mean, because when it is
Yeah. So I think steroids has got a clear-cut role. It's only when there is, a low oxygen level, and steroids definitely shows improving in mortality, but not till then. And that's the only thing that has proven to be some benefit in treatment. So I think if there's a right indication, we can start steroids on him. So the thing to understand is the treating team, as Dr. Raji mentioned, has started everything. And that, again, there's various protocols in different countries, different states, they all follow their protocols. So I think in Kerala, as far as I know, we do give antibiotics, azithromycin, we give antivirals, they've been giving plasma, everything they're giving. So that will be the treating team. And as far as we are concerned for Ramesh, they must have done all those things and is still breathless. So that's what we're thinking about. How will you make Ramesh comfortable now? How will you make him more symptomatic?
And meanwhile, Sunita, Rodoro has come with a suggestion that is intubation is a possibility. So what do you think about intubation? Because Ramesh is, considering his age and comorbid illnesses, worsening disease status, do you think intubation is a right decision here?
Yeah.
Probably not.
So, Rodor, I think the question to ask is Ramesh going to survive an episode of intubation, or is he going to have a prolonged intubation and then, is he not going to come out of that? That is the main thing for us to ask.
Vidisha has come with the suggestion we must talk to his family. They said no pain. He should be made comfortable. So definitely that aspect also should be considered.
I believe we've got some palliative, care physicians and those who've experienced of palliative care here. So, please come forward to think about the non-pharmacological methods of managing breathlessness. If you can think of something, what do you do in palliative care specifically to manage breathlessness? And again, not just palliative care. If a breathless patient comes, you've mentioned antibiotics, you've mentioned steroids. What all do you normally give? What else are we still missing? Morphine the right doses, yeah.
Morphine the right doses. Oh, very good. As Sunita has highlighted, could you suggest some non-pharmacological measures as well? Manage anxiety, definitely that is needed.
Yeah.
Any non-pharmacological measures which might be of help? Meditation is good, but it's good. I'm not against, but think of Ramesh status right now. Cool wet cloth on face, very good, very good. Morphine, oxygen support, antibiotics, antivirals if needed options. Just like Helen has mentioned, cool wet cloth on face, some non-pharmacological interventions, could you suggest some more? Diversion therapy, prone position, elevated head side. Okay.
Fan and a good
ventilation. Fan. bit cautious about that in ICU setting because of aerosol dispersion, but definitely that is a good pharmacological option for managing breathlessness. Okay.
Okay.
Ventilation is very good. Cross ventilation to the room and the area should have good ventilation. Okay, Sunita.
Okay, yeah. So I think I'll explain a bit about, even though I've covered this in webinar, just for the interest of today's class, why is breathlessness so difficult in COVID-19? And you can see that there's a complex pathophysiology is involved, including the cytokine storm and all the hyperinflammatory stage. All these will contribute to that. But in addition to that, in addition to the pathology itself, there's that vulnerability when, as we know, Ramesh is very anxious, age advances, comorbidities, trajectory becomes worse. So Ramesh himself is anxious about that. That can contribute to the breathlessness. Then the patient himself is loaded with lots of information. There's from media, social media, newspaper. There's lots of information loading. That will contribute to the anxiety, and that will make breathlessness worse. There'll be other psychosocial issues of guilt and fear of spreading the infection to other people. So all these actually should be factored into the symptom of breathlessness. So we can't just manage the breathlessness just with the pharmacological as a single symptom. It's a complex, multifactorial causes that is causing the Ramesh to become more breathless. So we need to address all those to make him more comfortable. As we discussed, what we again, I'll be following what's mentioned in the ebook. So what we suggest is that to continue with the COVID-19 management protocol for Ramesh as per the treating team is doing, and correct the correctable factors. So with things that we haven't actually mentioned in our discussion would be, he could have a bit of fluid overload, so you could give some diuretics for him. So laces can be given. Nebulizers, because it's aerosol generating, we don't recommend in this current scenario. So treat the bronchospasm if present, but once all this is managed, then other thing we shouldn't forget is that raised D-dimer. So give him some thromboprophylaxis or even treatment dose of low mercury heparin. So think of all the other causes that can make Ramesh more breathless, and manage them all medically. Give him oxygen support, and then he's still breathless. Then when we say the term of refractory breathlessness, where we define it as breathlessness not improving despite optimal medical management. And that's when we go towards the palliative care management or symptom management of breathlessness. So we mentioned non-pharmacological position has been mentioned, relaxation techniques, various breathing techniques can be tried. Now again, non-pharmacological management of breathlessness is as such is a topic on its own. There's lots of new studies have been done on that. There's lots of techniques you can try for that. There are some breathing exercises which I mentioned, including relaxed tummy breathing, calming hand technique, appropriate positioning to give him the maximum comfort, including sitting upright, legs uncrossed, let the shoulders droop down, keep the head up, lean forward. And especially for COVID-19, to improve in the recovery, what they suggest is that you can spend periods of time in prone position. You must have heard about that, including prone ventilation as well as prone position as a nursing position is supposed to be improving the oxygenation. Now, other relaxation techniques can be tried again if you can get hold of physiotherapists or nurse practitioners who are trained in that. You could teach that to the patient, and you could try that. All these might not be applicable in the acute crisis, but if it's properly taught at the right time, you could ask the patient to try that. And one of the breathing techniques that is described is you smell a flower and blow a candle. So pursed-lipped breathing, that also can be tried. Now, other non-pharmacological techniques, including reducing the room temperature. Dr. Helen mentioned about the cold flannel on your face. Fan is a very good non-pharmacological mechanism, but again, because of the aerosol generating, we haven't advised fan as relief of breathlessness in COVID-19. All the others we can try. And coming to the pharmacological management. Now, again, one of you have mentioned morphine for breathlessness. I don't know how many of you are familiar with that. If you could just maybe put in the chat box, as if you have used morphine just to manage breathlessness, you can just put an S in the chat box. So at least we can know how many of you are familiar with using morphine for breathlessness. And these doses that we give here are just suggested doses for the current, and the doses can be increased or decreased depending on your patient condition. So we can use both morphine and benzodiazepine to manage breathlessness. About morphine, if you're not familiar with the use of morphine, I would just like to mention a few words about how you can use morphine. How morphine works is that morphine will reduce the hyperventilatory response to hypercapnia, and so the respiratory rate comes down. And when the respiratory rate comes down, the work of breathing comes down. Other ways, it can cause pulmonary vasodilatation and cause better ventilation perfusion ratio. It's also used in pulmonary edema along with diuretics, and it's got vasodilatory properties. It also causes sedation of the cortical centers, and therefore the feeling of breathlessness also comes down. So there's lots of studies now, even randomized controlled trials, which shows the evidence of morphine for breathlessness. So what we are suggested is the starting dose of morphine, and how we have described that in our ebook is we've divided the patient into mild to moderate breathlessness and severe breathlessness. And for mild to moderate, we have given one starting dose, and for severe breathlessness, we've given a different starting dose. And this is all described as an algorithm in the ebook. So once you get a chance to go to the ebook, you'll be able to understand that. The starting dose we've suggested is morphine 2.5 to 5 milligram per orally every 4 hours, or 1 to 2 milligrams subcut, and midazolam 2.2 to 5 milligram Q4 hourly, slow IV or subcut. And or you can also use lorazepam sublingually if that's available, and if that's what you prefer, if subcut route is not available. Now, as we all know, again, for palliative care, we prefer continuous infusion, and that too you prefer subcut route as opposed to IV route. So if the patient is having continuous symptoms, once you give a start dose, always start an infusion with, again, it's a suggested dose only. It can decrease or increase depending on the patient and the symptom. What we suggest is a starting dose of 10 milligram of morphine and 10 milligram midazolam, IV or subcut over 24 hours. So there are a few people who have mentioned they've used morphine, for breathlessness. The other question I would like to ask is, how many of you are familiar with the use of subcut route or subcutaneous route as a way of giving injections and infusions? And how many of you actually use continuous infusion subcutaneously? Please type S in the chat box. This is the algorithm that I've mentioned. It is in the page 14 of the current version of ebook, where we have divided the refractory breathlessness into patient in ICU and patient in ward. And the only difference in as far as the algorithm is concerned from ICU and ward is we've used a different medication. We use fentanyl for patients in the ICU, mainly because of local preferences. Again, we haven't used fentanyl for ward, but again, you can still use it if it's available and if the nursing staff is happy to use that. Also, fentanyl is preferred if the patient has got renal failure. But as in our scenario, fentanyl is not that commonly available for palliative care as opposed to morphine. So that's why morphine is a preferred first-line opioid. In this algorithm, the non-pharmacological measures are mentioned in the first box, and then we've got the pharmacological, where we're divided into mild and moderate, and the last box is where the significant respiratory distress, so where we've given a respiratory rate of more than 30 at the end of life, and we've given a slightly higher dose of morphine. Again, all these patients would already be on a lower dose of morphine initially, and then we're gradually titrating it up to the higher dose, and we've also given the doses for fentanyl. So please refer to the algorithm, page 14 in the ebook for this algorithm. Okay, I think I'm getting some chat questions, and Dr. Raj is replying to that. Some people have used subcutaneous route, so that's good. If there's any questions you'd like to ask, you can put in the chat box and we'll try and cover it. I'm moving on to Ramesh, coming back to Ramesh again. So Ramesh has been started on some morphine infusion. He's actually very stable, has been stable for a couple of days, but then staff has suddenly noticed that Ramesh has become more agitated. He's mumbling incoherently. He's trying to remove his mask. The nurse looking after him also feels that he is frightened. Now, what do you think is happening now? What do you feel is the cause of his symptoms now? And how do you assess and manage a new problem? So what's happening to Ramesh now? Please put in your chat. So Ramesh, who's been settled for a couple of days, has become more agitated and trying to get out. So what's happening? Anybody? What do you think will be happening for? Yeah.
Sunita, meanwhile, we have a couple of posts.
Okay.
Like morphine fentanyl combination, like no, low-dose morphine with fentanyl patch.
Again, fentanyl, we've only given a dosage for IV fentanyl, mainly because patches, as we all know, will take some time to start working. So this is an acute crisis, an acute scenario. So starting a patch would not be able to help a situation initially. What you could do is, if you're comfortable with the patch, what you could do is you can start him on an infusion first and then place a patch on, continue the infusion for at least 12 hours. And then once the 12 hours over, the patch will start working. You can stop the infusion, continue with the patch, and then give bolus SOS in between. So patches, it takes some time to titrate. So always at that, crossover period, he'll need some SOS boluses. So you could give morphine SOS with a fentanyl background patch as long as it's a stable situation. And again, fentanyl, it's only been tried for pain, but we just extrapolate and we use, because it's an opioid, we use blood tests also. All the studies for blood tests are with morphine. But if patch is available, the patient's comfortable with that, you can always use fentanyl patch. But there is you have to manage a crossover time. Yeah. So somebody has mentioned delirium.
Yeah, delirium.
Yeah. And does he have fever? Yeah, even fever he had fever initially. So that also can make him more delirious. You're right. Yeah.
Delirium due to sepsis, hypoxemia, uremia, electrolyte imbalance. Yes, delirium could be multifactorial.
Yeah, definitely. So you have to think of all those things. He's definitely become confused. It could be delirium. It can be because of the sepsis going on, can be because of hypoxemia, uremia. So do the bloods, try and correct as much as possible, just like any other patient who presents with delirium. Okay. Just to mention a post that was posted on the COVID-19 palliative care providers, where people have described about the patients that seen with very bad delirium. Again, there is a mixture of there are some recent studies from UK which shows that delirium is not of much of a problem, and only lower dose of medications has been tried. But there are some anecdotal experience of having very bad delirium in COVID patients. So where nothing seems to be working, and they have labeled it sort of like a COVID-induced delirium. And this is another one that came from the British Geriatric Society, where what they've actually mentioned delirium as an atypical presentation of an older adult with COVID. So this it says that in the first slide, it says watch out for delirium, false syncope, anorexia, fatigue or malaise, GI symptoms, deterioration function, and day-to-day variability. They even might not have cough or dyspnea or temperature. So they have seen older adults, elderly people presenting with all the non-specific symptoms, including delirium, but not the typical symptoms of cough, dyspnea, or raised temperature. So something that you need to think in your mind when you deal with elderly patients. So how do you assess for delirium? Again, this is given in the webinar. The tool that we have suggested, again, nothing has been evidence-based. As for COVID-19, this is the simplest tool that we have suggested. There's lots of tools available. This is a 480 tool. Where you score for alertness, AMTS, that is abbreviated mental test score, attention, and acute change in fluctuating course. So for the AMT purpose, we asked patient's age, date of birth, name of hospital, and current year. And if they make 2 or more mistakes, then they're untestable, or they're untestable, they're given a score of 2 for that. So similarly, we scored each of these items. And if the total score is more than 4 or above, then it's a possible delirium, and the advice is use a delirium pathway. Again, for COVID-19, how much you can do this for this patients depends on your patient, but this is the simplest tool that is available to actually assess for delirium. these are the other causes you can think of. So other causes of delirium that you should be thinking of. So one thing is we haven't mentioned in discussion is pain. So pain could be an important thing that patient might be having and can present with delirium. So think of, you've mentioned uremia, you've mentioned electrolyte imbalance, other causes, and other things are obviously breathlessness we have covered. Don't forget things like urinary retention, constipation, the simple things which needs to be managed that can make the patient delirious. And also other one is a withdrawal syndrome, which is very relevant in the current scenario with lots of lockdown. And even if the patient has been already on opioid medications and not able to get the correct dose because of the lockdown or because of lack of medication, they can withdraw from the medication that they're normally taking. So all these need to be thought of and try to be corrected as far as delirium is concerned. I move on to the next algorithm in our ebook, which is algorithm 3, where we have described the management of delirium. And here how we have presented is that we have the patient is agitated, like Ramesh is agitated. We have divided into two: agitated and disoriented patient, that is a proper delirium, or agitated patient but he is oriented, which can be because of anxiety, panic, or fear. And these are the suggested medications that we have mentioned to manage. So again, we have divided that into mild and moderate. If the patient is delirious properly, so he's agitated and disoriented, and with mild symptoms, the medication that we have suggested is haloperidol, and the doses are, again, can be vary depending on your patient's symptoms. You can give 1 milligram slow IV or subcut, or 1.5 milligram orally, and it can be repeated every hour up to 5 milligram. That is the first line treatment. And if the patient is agitated and anxious, but he is not disoriented, then the first line that we suggest is a benzodiazepine. So suggested lorazepam or clonazepam. And if that's available, if the patient is not able to solo, we've given midazolam. Again, for the chat box, for the purpose, are you familiar with these medications to be used for delirium, including haloperidol and benzodiazepine? If so, please put S in the chat box. And again, patient becomes moderate delirious, some moderate symptoms. We've changed the dose slightly up. And the last box is intractable or severe symptoms. What we've given is again this continuous infusion. So we've suggested a dose for a continuous infusion of haloperidol 20 milligram and with some 30 milligram as a continuous infusion. And all these doses are suggested doses. The audit from UK shows that these probably are the maximum dose that they also have tried in the patients, and patients have settled with that. I'm not sure whether you're all familiar with antidrug levomepramycin, which is not available in India. That's why we haven't included in the guideline. But I know that we can use levomepramycin UK. That's the other alternative to haloperidol that we use for delirium there. So Tricia has mentioned, usually midazolam, haloperidol is often not available in our hospital. So, so that is the antipsychotic. So then you must be having some sort of alternative to haloperidol in your hospital. So again, depending on which drug is available in your hospital, you can actually use the algorithm accordingly. I'll just mention about pain management. This is purely the WHO ladder, where we divide the pain into mild, moderate, and severe. And the doses that the medications that we're given is what we do in normal pain management, so including paracetamol, and moderate we go to a step 2 opioid, that is tramadol is the one that is available in India, so we've gone for tramadol. And the severe pain, go to oral morphine. Or transdermal injection, fentanyl. So again, patches, fentanyl patches is available in our country now, but patches are more expensive, and even injections are expensive. So, and patches always, you make sure the patient's got a stable symptom before you apply a patch, or you stabilize the symptoms with a short-acting one, and then they apply the patch on, and then stop the short-acting one. So that's how we normally change from one opioid to the other. I'll conclude with mentioning the list of essential medications. This is a WHO and IHPC list that has been adapted, and we have put that, and the medication that is given in bold is what we have mentioned in the ebook. So for different symptoms, these medications has been mentioned in the ebook. So we've just made that in bold, but these are the list of medications that should be, ideally available when you deal with patients with in any patient with any palliative care symptoms, these are the list of medications as according to WHO that should be ideally available. Okay, so just to conclude and to summarize, we need to recognize that it's a symptom complex of breathlessness and agitation. So just like what happened to Ramesh initially started with breathlessness and then he went on to be agitated. So what happens is that what they normally see is the patient is very, very breathless, anxious and agitated. So it's a symptom complex of breathlessness agitation that is severe COVID-19 pneumonia. And that's how, the patients ultimately die. So we need to make sure we manage them both. And as I mentioned, if you're familiar with the use of continuous infusion, what I need to say once again is that all these medications can be combined together. So in the case of Ramesh, when he becomes agitated, what we can do is we can add the 3 medications together. So he needs morphine for his breathlessness, and then you add midazolam and haloperidol for his agitation, and you give a continuous infusion of morphine, midazolam, and haloperidol together in a syringe pump over 24 hours. So that's how we can manage a symptom complex of breathlessness and agitation. And opioid should be made available to manage breathlessness. The 480 delirium tool is a quick tool to use. Always remember to rule out and manage other causes of delirium. And for anxiety, restlessness without disorientation, if the patient is oriented but is anxious or agitated, you start with the benzodiazepine. If the patient is restless, agitated, with disorientation, you can start an antipsychotic. And for those of you who are new to palliative care, I would like to say is that this can be applied to other patients also. So any patients that you feel, has got palliative care needs and palliative care symptoms that can be assessed, you can feel free to use our algorithm for other conditions also. So probably it'll be more useful to you even after the post-COVID scenario. If you deal with patients with palliative care needs, you can actually use this algorithm for that. These are the further resources and training that's that can be used even for palliative care as well as for COVID-19 related. Sorry. Okay. Okay, I think I've come to the end of my session. Is there anything in the chat that we need to discuss about, Dr.
Tricia was using midazolam for the management of delirium in her setting. Probably, I believe she doesn't have haloperidol available in the hospital. So I was commenting midazolam or any benzodiazepine is not the drug of choice in the management of delirium unless it is hyperactive and the patient is in restless state. So she said, she was telling, yes, that is correct, but unfortunately halo is not available. So that's the reason why they use midazolam, but they primarily focus on the etiology of delirium and they correct it and they blend it with non-pharmacological measures. So that is good.
Okay. So I've just given you 2 links in the chat box. So one is from BMJ Best Practice, where it's a very good resource actually. BMJ Best Practice, they update this very, very frequently. So most of the content of this presentation is actually from BMJ, because what they've done is they've collected evidence from all the available studies and papers that's published on COVID-19. And this link will take you to the long COVID page where it tells you about what all has been done and what all can be done. So feel free to go through that. And the second link that I've actually given you is there's a new guidance that has come from the European Respiratory Society. They have done a consensus study. So they've actually asked a lot of palliative care, including and respiratory physicians, about what sort of guidance on palliative care can be given in COVID-19. So we all know that when we develop guidelines, we should have some experience of using all these medications or using all this management for COVID-19, and you have to publish them. But that we haven't done that, and we can't do that way. So what they've done is, just like we developed this ebook, they've done a consensus on all the experts on this field, and they've asked particular questions, and they've collected the evidence from them, and that has been published as a consensus on what all should be done. And what they've mentioned is actually covers pretty much like what we covered in our resource toolkit also. Basically, we need to manage symptoms very well. We need to have triage, we need to have goals of care discussion, psychosocial symptoms should be managed. Communication is very, very important. Advanced care planning, clinician-patient communication, all these things. Spiritual care is very important, and bereavement care. So this is a most recent one that has been published, I think probably last week or something. So I've given you the link for that. Please feel free to go to, it's an open access one. So please feel free to go through that. Any other questions, anything else that is not clear in today's presentation, or anything that you would like to ask about palliative care in general? I think we've got some time, about 10-15 minutes. So please feel to ask some questions. Including morphine access. So if you could, now people who's actually, if you have got opioid access, if you don't have any morphine access, please type no in the chat box. So we'll know that, who all don't have morphine access. That'll be quite useful.
It's difficult to distinguish agitation from pain. Rose, could you just explain more about that? I mean, have you seen it in a patient who is not able to verbalize and tell that he is in pain or not? In hepatic encephalopathy, where the patient is disoriented, it seems it is difficult to distinguish between whether the restlessness is due to delirium or pain. That is what you mentioned. Am I right? Yes, okay. See, nothing is hard and fast in medicine, so probably we may have to see, agitation, of course, to distinguish whether it is pain or it's from delirium. Pain itself can be a causative factor to delirium, isn't it, Sunita?
Yeah, definitely, yeah.
Unrelieved pain can be a causative factor for delirium. So probably we have to go by the verbal cues. When we change the position of the patient, or when we are doing some procedures or some other nursing maneuvers, if the patient winces or frowns, the patient may not be in a position to verbalize, but we can go by the non-verbal cues. So probably we can have a trial with the baseline analgesics, because encephalopathy is a tricky situation where we will not be able to try high doses of opioids. In hepatic encephalopathy in particular, we may not be able to use paracetamol as well. But still, in a decompensated hepatic failure, if you really want to have good symptom management, I would say I would go ahead with paracetamol at a lower dose. Meanwhile, what's the maximum dose of paracetamol which we can give in the chat box? Maximum dose of paracetamol. Hello. Maximum. Am I not audible?
No, ma'am, you can.
4. It is 4 grams. In decompensated hepatic failure also, we will not be in a position to save the patient by not administering paracetamol. Here also, I think we can give up to 2 grams of paracetamol a day. That's what Rajagopal sir used to say. So, with that paracetamol, if you can achieve some pain relief, so that itself will make the patient comfortable and may partially relieve the patient from delirium as well. In delirium, for symptomatic management, probably we have to try an antipsychotic. That is always the first line of treatment. Moira is in line. Moira, do you have any comments?
No, I think this is an excellent discussion. I think I just wanted to highlight something that Sunita said. The evidence coming out, because we're all learning together, is that basic symptom control is working well in this setting. So I can see some of you have access to different medications. That the key medications we need are good medications for sedation. Ideally, haloperidol and benzodiazepine are good medications for breathlessness. Ideally, opiates and benzodiazepine. We're not seeing high levels of pain due to COVID-19 itself, though of course people may have other problems that cause pain and then also develop COVID-19. So I want to reassure people that of course these are some tricky, complex settings, but most of the time good practice can make a difference. I did wonder, we've got a lot of nursing colleagues on this call, and I did wonder if they had any specific questions about nursing issues. I think, Sunita, you mentioned the issue of nursing prone. Did you mention that? You want to, yeah, you want to mention why that's been seen to be beneficial, Sunita?
It's supposed to be improve the lung recruitability and improving in the oxygenation of the lungs. So it's actually for recovery rather than any symptom management one. For the symptom management is basically its proper position to make him more, less breathless. But for COVID-19 as such, for lung recruitability, the prone position is advised. So that's why I mentioned that, yeah.
So I wanted to ask you two, both of you as very senior colleagues and good friends, one of you've covered the symptom control very nicely, and there's been some great discussion, and please also be aware that there's some helpful algorithms to work through in the ebook. But one of the challenges, of course, is this whole business of how we explain these symptoms and why we're doing certain treatments. So given the years of experience you both have, I wonder if you could just comment for our group, because this was a key issue yesterday. In order to start all these treatments, we need to have discussions with the patients and the families. How have you found it doing that with patients who are this sick and with families who are distressed? Any tips or suggestions from either of you, Dr. Raji, Dr. Sunita?
Is it just with COVID-19 or is it generally?
Well, I think the same comments are there generally, isn't it, with just a bit of added fear and anxiety. So just some tips from you as experts to our group here. And if anyone else wants to give tips, please put them in the chat. But I wanted to give both of you the chance just to share your experience.
Yeah, I think just like we mentioned, it's always about communicating, and face-to-face communication is very, very important. So with COVID-19 in this current scenario, that is something that we are struggling with. Even though personally, I haven't seen any patients with COVID-19 because my center is a non-COVID center. Other patients with, cancer diagnosis, we now have a social distance. So we don't even, the patients and bystanders even don't even sit near to us. So quite far away in the OP room we are talking. But the whole thing is probably what I tend to do is first trying to understand how much they understand, the patient or the bystander, how much they understand about the illness. So it's always better to give them the chance to say first, and then from then on, then I take on. Sometimes they might not know anything about the disease, and we'd have to start from the very beginning saying that you had this symptom and you had this test, and do you know about the test showed, and then do you want me to tell you that? And then they say, and then I say, okay, this is what it showed. It's unfortunately, it's a tumor. It's a common language that they use. Cancer is cancer. And then do you want to know further? And then if they want to know more, then obviously they say yes. And then we go on to say that so much can be done for you as a curative treatment. But if you've got any symptoms, we'll be able to help with that. So what we can say is we probably might not be able to cure you of your illness, but we can make you more comfortable, and we can help you cope with the illness. So that's how this is for the cancer diagnosis that I'm talking about. I haven't seen any COVID-19 patients.
So thank you, Sunita. So you're identifying the importance of checking, understanding, and then of going step by step and being clear about expectations, but also reassuring that we are not going to abandon people and we're going to keep working to make sure they're comfortable as possible. Raji, a question yesterday came, what do we do when the family members are not willing to accept, for example, not escalating to ICU? Some of the staff yesterday were saying they were finding that very difficult. How do you handle that, Raji, when families want more of the curative intent treatment than we feel is ethically and clinically indicated, Dr. Raji?
Myra, am I audible?
You are.
Okay. I think we are speaking from the non-COVID scenario as well, because I too, just like Sunita, haven't seen a COVID patient yet. So in the general setting, it depends all a lot on who is going to be the beneficiary, whose interest we are just looking at as a priority. And it's principally focused on the patient. So if the patient doesn't want an aggressive or invasive or ICU measures, so it makes the job easier for us so that we can talk to the family, with respect to the patient's comorbid condition and the patient wishes, and if he is being pushed to ICU or any aggressive measures, how, badly it can affect his physique as well as the morale. That is easier. But if the patient doesn't understand, and if we come to a situation so acutely, so sometimes it happens, it's very tricky and challenging. So that means there will be a lot of family caregivers will be surrounding us to get the opinion and the suggestion for the kind of debate and all. So I prefer to choose among themselves. I give the option to them. Could you please find the two most responsible or the most acceptable two people can come forward to have a discussion or to generate a discussion. So then I will start from the very beginning, with an open mind, as I had already posted in the chat box. So how it happened, what is their understanding, what are their expectations, and then if that expectation works, then it is well and good. But what is the plan B if that doesn't work? If that is going to cause some more harm, then do you have some other plans in their mind? So in such certain conditions, like Moira, we are also in a shady area, like a gray zone. Whether this particular management is going to benefit the patient or not to benefit the patient, we are also a bit unsure. So we will stand on a common platform saying that, okay, if that is the case, we will give a try for some half an hour or 1 hour or something like oxygen therapy or something like that, or even for 24 hours. So after that, if that is not going to be fruitful, then we may have to take a decision like withholding or something like that. So that is one strategy I would adopt if family members are found to be not yielding as easily as I think. Otherwise, if I can convince them, I will move ahead with withholding itself. The first is withdrawing, and the second one, if they are yielding at the first talk itself, it will be withholding.
Thank you, Raji. And that nicely links yesterday's session to tomorrow's session. And of course, we've covered the symptoms. I think, Sunita, you've just shared some indications of non-verbal indications of pain. Are you wanting to say something about the ones you shared?
Yeah, it's for the question that one of you asked about pain and hepatic encephalopathy. So basically, it's go and you try and assess whether it's non-verbal indications of the pain. So the patient can have labored breathing, they can be hyperventilating, moaning and crying, grimacing, frowning, body language, clenching fist, especially during nursing care. So I think nursing colleagues can actually tell us. For me, in my personal experience, always been nursing colleagues who's been telling me, doctor, when you do rounds, that I think when we did cares for the patient, she was grimacing, she was frowning. I think she's in pain. So nursing colleagues are very good at picking that up. So that's how we basically assess patients who are disoriented and whether they've got pain or not.
Thank you. And of course, we have these skills also from assessing children who are non-verbal. They're slightly different, but we're still looking at these behavioral and physiological changes and asking the caregivers, the nurse or the family caregivers, if they are there. I'm seeing just that, just a reminder from Arun, who's our host, that if you've logged in with a name of a phone, we won't be able to register your attendance. So please, if you're one of those numbers, just register your attendance. And we've pretty well come to the end of the session. Any last comments or queries as we just conclude this session together? We've covered now triage and ethical issues. We've looked at symptoms today. And all of these things connect, as we've already said. So tomorrow we'll be looking more specifically at communication, again looking at Ramesh's family and the particular situations there, but extrapolating that to the situations we find ourselves. I want to thank you very much for the interaction and the mutual learning, which is so important. And May, you've reminded us again, you shared yesterday about the importance of compassion, not just in the way we communicate, but in the way that we offer holistic care. And I think this has underpinned much of what we're talking about this week. And it also underpins how we need to respond ourselves. Previous courses, people have taken the opportunity towards the end of this course to talk about the impact it's having on them personally. So please feel free to do that and talk about how we can be compassionate in our care for others and compassionate in our care for ourselves at such a difficult time. I think if there's no further questions, I want to thank Dr. Sunita and Dr. Raji extremely much for an excellent session. Thank you all for joining in and contributing. And I will pass over to Pallimindian just to conclude our session today. Thank you.
Thank you, Moira. Thank you, Moira.
Thank you, Moira. Thanks.
Facilitating us also, like, I mean, those questions were, I appreciate them very well. Unexpectedly, you drew all of us to a loop, and that was really rewarding. And thank you so much for that kind of facilitation. And thank you, Sunita, and thank you all participants and PalliMindia. Please fill in the feedback form too. So meet you all tomorrow and day after tomorrow and good night.
Okay, thank you, Sunita ma'am. Thank you, Rajasri ma'am. Thank you, Moira ma'am. And today also we don't have any live phone due to some technical issues. And I shared the feedback link on the chat. Please do it now. It's a request. And the same link I will share on the WhatsApp group also. Okay, thank you.
Ah, bueno, eso